This is chapter 33, a review of the urinary system. Okay, so I did post a video on Blackboard for you that gives you just a quick brief overview of the urinary system and how it functions. So take a look at that video as well. But when we talk about the urinary system or the renal system, it consists of 2 kidneys, 2 ureters, 1 bladder, and 1 urethra. So the kidneys constitute a major portion of the renal system, and they're bean-shaped organs that lie on each side of the spine at the small of the back. The left kidney is positioned slightly higher than the right kidney. And then you have the adrenal glands on top of the kidneys to help influence blood pressure as well as sodium and water retention by the kidneys. So the functions of the kidneys, they help to regulate fluid and electrolyte balance, eliminate waste, maintain acid-base balance, and it does that by secreting the hydrogen ions in the urine, regulate the blood pressure, increase the red blood cell productions, and they help to metabolize vitamin D. So based on your fluid intake, the total daily urine output could change. But on average, approximately 200 liters of urine, or liquid, I should say, 200 liters of liquid is filtered by the kidneys in a 24-hour period. And around about 1.5 to 2 liters is excreted as urine. But say, for instance, your patient drinks a large amount of fluid, the urine output will likely increase. And if your patient restricts their water intake, or say has an excessive amount of intake, such as like sodium or something like that, then the urine output is going to decrease, and the body's going to start to retain water. So it just kind of varies. So, your patient should be having an average, and we'll talk about that urine intake in a day. Okay, so just as you have 2 kidneys, you have 2 ureters, 1 ureter for each kidney, carrying urine from the renal pelvis to the bladder. And it does that via peristaltic waves that occur. And so the urine travels from the kidneys through the ureters to the bladder. So the bladder is a hollow muscular organ in the pelvis where the urine is stored until it is excreted from the body. So the bladder can hold on average about 1,000 to 1,800 mLs of urine, which seems like a lot, but you probably shouldn't, continue to overextend your bladder on a regular basis. As you're younger and you're holding that bladder for long periods of time, the muscle starts to weaken, and so as you get older, as if that muscle is weakened and stretched out over time, you have different types of incontinence or things like that might occur from that weakened muscle, which we'll talk about later. But on average, it can hold about 1,000 to 1,800 mLs. But you can probably start to feel the need to void or urinate when you have about 150 to 200 mLs of urine in the bladder. um, from the bladder, um, when you feel the need to void or whatnot, from the bladder, the urine goes through the urethra and on out the urinary meatus. And so you have that internal sphincter is okay. So the ureter. So from the kidneys, the urine travels down through the ureter. So you have one ureter for each kidney. And so the urine travels from the kidneys via the ureters via peristaltic ways to help, push the urine down into the bladder. And so the bladder itself is a hollow muscular organ in the pelvis, and it serves to store the urine that comes out of the ureter. So it stores the urine until you're ready to release the urine or urinate. So the bladder can hold, on average, 1,000 to 1,800 mLs of urine at a time. But, as we'll talk about, some age-related changes, you don't want to just necessarily hold that urine for extended periods of time, constantly stretching that bladder out of shape and the muscle and stretching the muscle out of the shape. And so when you're younger, you keep doing that. And by the time you get older, you'll have, issues with maybe incontinence or dribbling or something like that. If that muscle, gets out of shape, if you continuously allow yourself to overextend that bladder. And so typically, on average, you can start to feel the need to void or urinate when the bladder reaches, has about 150, 200 mLs of urine in it. You can probably feel like, oh, I probably need to urinate or whatnot. So from the bladder, the urine passes through the urethra. And so when you're ready to urinate at this point, the urine will pass through the urethra. You have an internal sphincter and an external sphincter to help control this. So the internal sphincter is located between the end of the bladder and the top of the urethra, and that's an involuntary. It's involuntarily controlled. So when you get ready to urinate, that sphincter will relax and allow the urine to be released from the bladder into the urethra. Then you have an external urethral sphincter, and that external sphincter is located. It's on the other end of the urethra, so between the urethra and the urinary meatus when you're getting ready to urinate, and that one's controlled voluntarily. So you voluntarily relax that sphincter so that urine can exit the body at that point. Okay, so let's talk a little bit about some age changes or age-related changes when we're talking about the renal system. So our kidney function may start to decrease when we hit the age of 45. Several things may start to happen. In men, the prostate gland may hypertrophy, which means enlarges, and can cause obstruction of the urinary flow because, as you know, the prostate gland actually surrounds the urethra. So if it's enlarging, then it's going to be putting pressure on that urethra, which could possibly prevent urine from flowing appropriately through the urethra. Also, we might have a decrease in aldosterone, which could, affect our ability to regulate the blood pressure appropriately, or vitamin D, which is going to cause issues with the bones and muscle weakness and things like that, degenerative changes in the bladder, causing incontinence or residual urine. I remember, like I said, you holding that bladder for extended periods of time when you're younger, instead of urinating when you need to and just holding that bladder and stretching that muscle out of shape over time. That can cause, affect you if you allow that muscle to continually be stretched out of shape and weakened. Bladder capacity may decrease to as little as 200 mLs, which is not very much. And so you might notice your elderly patients having to go to the restroom quite frequently, back and forth to the restroom. And then as a result, they might start decreasing the amount of water that they drink, so that they don't have to go to the bathroom so much, or so that they aren't incontinent or whatnot. So then they decrease the amount of fluid that they're taking in, which is going to cause, additional problems. You run the risk of dehydration and some of the other things that we'll talk about if you're limiting your fluid intake by doing that. So as we get older, we tend to have a decreased ability to concentrate our urine, which puts us at risk for nocturia, which is urinating at night. And also with women, women tend to have lower estrogen levels as they get older, which causes a thinning of the urethra in the vagina and the bladder, which makes women more at risk or more vulnerable for developing infections and incontinence. Also with that low estrogen levels causing that thinning in the vagina, the area is more dry, the vaginal area is more dry, and so they may have pain with urination, or I'm sorry, pain with intercourse is what I mean to say, because of the vaginal dry areas. So you can teach them to use like a water-based lubricant or something like that to help keep the area moist. So a lot of different things can cause your urologic disorders, and we're going to talk about several of them in our next chapter here. But a few things like bacteria entering the urethra from outside and into the urethra, bacteria going up. And so we'll talk about, some ways to prevent that. Like, for instance, E. coli being a big factor of UTIs. E. coli found in the stools. And so that's why we tell women when they, after urinating, they wipe from front to back, so that they don't wipe the stool into have stool going up into the urethra. That's a common cause of bacteria getting into the urethra. Also, there's blood in the or there's bacteria in the blood that's being filtered by the kidney. So if there's something that's causing the fluid to just sit there, that bacteria can build up there and cause infections. So like you got tumors or kidney stones or different things like that, that's preventing the urine from flowing through. It's going to just cause it to sit there and cause that bacteria to build up, and you can get urologic disorders that way, or just issues with the stones or the tumors themselves can cause different urologic disorders. We talked about the enlarged prostate with men causing different urologic disorders, high blood pressure, diabetes. All these types of things can cause various issues if there's something that's preventing oxygen. So preventing blood flow to a certain area of the kidneys and causing a lack of oxygen to that area, all those type things. And so, like I said, we'll talk about several of those diseases as we progress on to next chapter. Okay, so there are some things we can do to try to avoid some of these urologic disorders and things. Drinking plenty of fluids, drinking plenty of water, 2,000 to 2,500 mLs of water a day to help flush the renal system. Like I've discussed in the previous chapters, you want to try to empty your bladder sooner rather than later. So number one, you're not allowing that urine to just sit in the renal system, building up bacteria or whatnot in the renal system. Also, too, like I said about stretching that bladder, and then when you get older, leading to a weakened muscle or bladder, causing incontinence. Controlling your blood pressure is another way to ensure or prevent urologic concerns. You want to also don't overuse your over-the-counter medications like your Tylenol, your NSAIDs, and ibuprofen and aspirin and stuff like that. You don't want to overuse those medications as well. Okay, so some diagnostic tests for urine. If you suspect a UTI or something like that or whatnot, you could do a urinalysis, and a urinalysis would tell you if there's infection or something like that. So it's going to tell you if there's bacteria, blood, or some type of abnormality. So if there's some type of infection or something going on in the urine. A culture and sensitivity is going to further tell you if you have that UTI, what specific antibiotics is that bacteria or whatnot sensitive to. So your physician or healthcare provider would know what what to prescribe you appropriately. The urine should be clear or straw to like a dark amber color. Is what the color should be. The pH tells you the acidity of the urine, and so that's 4.5 to 6. So it's on the acidic side, that your urine is more on the acidic side, because that's 4.5 to 6. Specific gravity is going to tell you how concentrated your urine is. So if the urine is more concentrated, then that could indicate something like dehydration or something like that. So a normal specific gravity would be 1.010 to 1.030. The urine should be negative. Meaning there should not be any proteins, glucose, ketones, or bilirubin in the urine. So when you're looking at these lab results, for your urine, you keep these things in mind. So patients could also have a renal biopsy that could, help determine the cause of any renal diseases, or determine if there's any malignancy, which means is it cancerous or anything like that. They also could you do it to evaluate if a patient has had a transplant. If there's any, are they having any rejection to the transplant? So things you want to teach a patient with that's having this renal biopsy, they should be NPO, which means nothing by mouth, for 6 to 8 hours before the test, and they have to lie on their back for like 16 to 24 hours afterwards. And sometimes your physician's orders will, give you some specific guidelines on that as well, how long they should be laying, flat on their back after the procedure. Avoid activities that increase the abdominal pressure, like sneezing, laughing, coughing, all those type things increase the abdominal pressure. So you don't want to do that. And let them know that about the first 24 hours after the procedure, the urine might have some blood in it, and shouldn't be alarmed about that. Should drink at least 3,000 mLs of fluid, unless they have some kind of condition that would contraindicate it, maybe, or if they're on a fluid restriction like with CHF, or whatever the issue might be. If they have a fluid restriction, if they don't have a fluid restriction, then they should drink like at least 300 mLs of fluid afterwards to make sure they flush their urinary system out pretty good. Shouldn't do any strenuous activities for about 2 weeks after the procedure. And then, like I said, the first 24 hours, they might see some, urine in the blood. But if they have any bleeding, or afterwards, or fever, or just weakness, or pain when they urinate, or whatever, they need to report those to their healthcare provider right away. So the BUN, or blood urea nitrogen, is one of the tests that you can have, a blood test you can have drawn to determine your patient's kidney function, also their hydration status. And so the BUN, if the BUN is elevated, then that's going to indicate a decrease in the patient's kidney function. So high BUN means decreased kidney function. And then a low BUN could be an indicator of like liver damage, or excessive hydration, or something like that, or some type of protein deficiency. So a normal BUN would be 7 to 20. That would be a normal BUN, 7 to 20. So a serum creatinine is another one. So your BUN and your creatinine are going to tell you your kidney function. And also, so a serum creatinine, elevated creatinine, is also going to indicate decreased kidney function. So remember both of those, elevated BUN and creatinine will, if those are increased, that indicates decrease in your kidney functions. And so a normal creatinine level is 0.8 to 1.2. So keep those things in mind. Those are some key lab values when looking at your patient's kidney function. If you're collecting a 24-hour urine, you want to start first thing in the morning, and you're going to discard your first urine of the day, and then begin with the 24-hour collection after that. So you start first thing in the day, the first urine you have that morning, you'll discard that, and then you'll use the collection container to collect the rest of the urine after that. Your book on the table 33.2 also gives you some detailed information on urologic diagnostic tests. Okay, so when you're doing a focused urinary assessment, you want to begin your assessment with a thorough history, including current and past health, their family history, and any lifestyle patterns that they might be having. To determine the patient's chief complaint, you want to ask what made the patient seek medical help. You want to document the reasons for seeking care in the patient's own words. When a patient has a renal disorder, you want to look at some common complaints that they might have, such as urinary frequency and urgency, pain on urination, difficulty urinating, or flank pain. Flank pain being the pain. Remember, we said that the kidney was located at the back, so at the lower back. So that's where you want to, make sure, see if they're having pain there. When we're talking about previous health status, explore all of the patient's previous major illnesses, recurrent minor illnesses, accidents or injuries, surgical procedures, any allergies. Ask about a history of any urologic related disorders, like even like hypertension. You might want to ask, have they ever had a urinary infection? Are they taking any herbal medications or prescriptions or over-the-counter medications, any recreational drugs or anything like that? Do they have any pain or burning when they urinate? Are they able to initiate urinating without difficulty? Ask them what color is the urine. Ask them, are they allergic to any drugs or foods or anything like that? Have they ever had any sexually transmitted diseases as well? When we're talking about a family history, you want to look for clues to any risk factors. Ask if any blood relatives have ever been treated for renal or cardiovascular disorders, or anything like diabetes or cancers or any other chronic illnesses or anything. When we're talking about lifestyle patterns, you want to investigate their psychosocial factors that might affect the way the patient deals with the condition. Any marital problems, unstable living conditions, job insecurity, any other stressors that they might have as well. So you want to assess all these things when you're working on your focus assessment for your patient. Okay, so when we're talking about our physical assessment, you want to begin by documenting the patient's baseline vital signs and also weigh the patient. Ask the patient to urinate into a specimen cup so you can assess the urine's color, any odor, and the clarity of the urine. So we want to do an inspection. So that includes examination of the abdomen and the urethral meatus as well. So you want to have the patient lie in a supine position, expose their abdomen, so that you can inspect the abdomen for any enlargements or fullness. Look at the left and right side to note any asymmetrical areas. In a normal patient, the abdomen should be smooth, flat, symmetrical. Ask the patient about any scars that you notice, or lesions, or bruising, or discolorations that you might find. As far as the urethral meatus, help the patient feel more at ease during your inspection by examining the urethral meatus last and by explaining to the patient how you will assess the area. Make sure you wear gloves, of course. Auscultation. You want to auscultate all 4 quadrants. You want to auscultate all 4 quadrants. And then when we're talking about palpating, we want to palpate all 4 quadrants as well for any tenderness. See if you feel for any bladder distension or anything like that. All right, so as far as nursing responsibilities in your daily assessment, you're going to likely be measuring the patient's I&O, so intake and output. You want to assess for any abnormal flow in the patient's urine, changes in the patient's in the urine with the color, the odor, the clarity. We already got our baseline, but we need to be assessing it on a regular basis. Are there any changes in the pattern and how the patient voids? Are they having any pain or discomfort when they're urinating? So you should be assessing all these things in your daily assessment for our patients with urinary issues. So these are just some terms you need to learn. Remember we talked about if you see that urea at the end, you know it has something to do with urine. So when we say anuria, that's no urine. Oliguria, decreased urine. Polyuria, a lot of urine. Nocturia, urinating at night. Urinary frequency means going a lot. Urinary hesitancy means having difficulty starting the urinary stream. Urinary retention means having difficulty emptying the bladder when you do urinate. And then residual urine, they might check the urine to see how the residual or how much you actually left in the bladder if you didn't empty the bladder all the way. So make sure you start to learn these terms and understand what each one means. So urinary incontinence is your inability to be able to control your urine. You're not able to hold it in the bladder or voluntarily hold it for various reasons. And we'll talk about some types of urinary incontinence here in a moment. But more women than men tend to have urinary incontinence, about 75%, and about 53% of our patients that are homebound are incontinent. And a large number of individuals, as you all know, in nursing homes are incontinent as well. Women that have had a lot of children might be incontinent just over time. That's why they teach you to do the Kegel exercises, you know, after children, to try to strengthen those muscles up again. The pelvic muscles, strengthen the pelvic muscles, where you tighten and release and tighten and release the pelvic muscles, trying to strengthen them up. The way they teach you is maybe when you're, you're urinating, hold your urinary stream, let it go, hold it, let it go, try to think of it like that as a way to build those muscles back up after having a lot of children. Men with, we talked about that, enlarged prostate can have issues with incontinence as well. And obviously our immobile patients, for various reasons, we talked a lot about those neurologic disorders that can cause incontinence as well. Our patients with UTIs. And when we talk about UTIs, we didn't talk about this with our older patients, but our older patients, when we notice a change in mental status or something like that, that's a key indicator for a UTI for our older adults, because they don't tend to have symptoms like younger people might have. They don't get the fever or things like that. They tend to get a change in mental status. So if you have a patient that's got a change in mental status, you might want to ask the doctor for an older patient, I should say, an older patient with change in mental status. You might want to ask the doctor for a urinalysis and culture and sensitivity, just to be sure they don't have a UTI, because that's a key indicator for them. Some other things that can cause urinary incontinence are stool impaction, delirium or confusion. A lot of medications can cause urinary incontinence as well, and obesity, because that tends to put a lot of pressure on the bladder as well. So some different types of urinary incontinence are urge incontinence. So urge incontinence is like, I got that feeling I gotta go right now, and I just gotta go, and I can't hold it. As soon as I get that feeling, I gotta go. Stress incontinence. So that happens like when you sneeze or laugh or cough or exercise or something like that, and you lose urine. Urine comes out on accident. Mixed incontinence is just a combination of different types of incontinence. And then overflow incontinence, that occurs when like you have some type of obstruction in the urethra. So like when we talked about that prostatic hypertrophy with men, that's the overflow, because there's an obstruction with that urethra, would be an overflow incontinence. So you have that obstruction, but then you have some urine leaking around that obstruction. So functional incontinence is there's some type of cognitive inability that you can't recognize the need to urinate. So maybe like dementia or some kind of cognitive functioning depression or something that is preventing you from cognitively recognizing the need to urinate. And neurologic incontinence, so that's, remember we talked about all those neurologic diseases that as the disease progresses, you get to the point where you might have some incontinence. So like the multiple sclerosis, all those neurologic diseases we talked about when we talked about the neurologic system would be considered neurologic incontinence. So some things we can do for urinary incontinence. So we talked about the Kegel exercises that were used to help strengthen those muscles. Medications, there's several medications listed in your book on page 782, table 33.5. Transvaginal electrical stimulation. So that's when the nerves and the muscles of the pelvic floor are stimulated to try to help prevent that urinary incontinence. You want to educate your patients. So like things like alcohol and all your caffeine, so that coffee and pop, all that stuff that's caffeine in it, those are stimulants, and those are going to increase the need to urinate. So those are like bladder stimulants, and so you want to try to teach them to avoid those type of things. And then some other things, they can have surgery. So especially like in women, they might have that bladder prolapse where the bladder falls into the pelvic area. So you have that retropubic suspension to lift the bladder. Or you can have an artificial sphincter implanted. And we talked about the sphincter, losing control of that sphincter. You can have an artificial one actually implanted to help prevent urinary incontinence if that is the issue, if the issue is with the sphincter.